good morning to all. Welcome to today's NIH CME session organized by Sector for Research Information Resources, National Institute of Health, Ministry of Health, Malaysia. Hi, I'm Komathi Perialathan, Health Education Officer from Institute for Health Behavioural Research, and I'll be your moderator for today's session. And today's CME session's title is Malaysia Health Literacy Survey 2023 Learning Points. So basically this session will share learning points on conducting a nationwide health literacy assessments via a collaborative effort with another institute. So before we begin our session, I would like to remind all our participants to register your attendance by clicking the attendance link provided in the description box below, because this will be important for CME points and certification. And in case later, we'll have a question and answer session whereby we welcome your questions for this presentation by our presenter. So please submit them via the question link that we have provided, available in the description box as well. We'll try our best to address all the questions that are posed if the time permits. Okay? And this session will be done after the presentation ends. Okay, without further ado, it's now my pleasure to welcome our wonderful speaker for today, Dr. Mohamad Zabri Johari, Health Education Officer from the Institute for Health Behavioural Research, NIH, and he's the lead researcher for the Malaysian Health Literacy Survey 2023. And Dr. Mohamad Zabri is my colleague as well. Okay, so I'm going to introduce him. Okay. Dr. Mohamad Zabri earned his PhD from the Institute of Health and Society, University of Newcastle, UK, with a specialization in public health psychology. A trained mixed methods researcher, Dr. Zabri brings comprehensive expertise in both quantitative and qualitative methodologies, with a strong emphasis on methodological development, research ethics, and project management. He has conducted several studies. I would like to name few. A qualitative study on delayed health-seeking behavior among cancer patients, process evaluation of enhanced primary health care intervention in selected government primary healthcare centres, exploring stigma related to health-seeking behavior among transgender and men who have sex with men, and youth behavioural risk surveillance study in 2013. And currently, Dr. Zabri contributes in NIH at a multi-faceted level. He serves as a member of the Medical Research and Ethics Committee and the NIH Research Review Panel, JPP NIH. Beyond NIH, Dr. Zabri is also a technical and commercial panel member with MOSTI and a member of the My Social Innovation Panel. Okay, he is also very actively engaged as an evaluator and advisor in various academic institutions, both public and private. A warm welcome to you, Dr. Zabri, and thank you for joining us today. Okay, dear all, actually before we start the session, Dr. Zabri's session, we would like to share a preview of our Institute for Health Behavioural Research corporate video from your kind reviewing. Then we will proceed with the presentation.
Institut Penyelidikan Tingkah Laku Kesihatan IPTK merupakan salah sebuah dari institut di bawah Institut Kesihatan Negara. IPTK bermula sebagai sebuah unit di bahagian tingkah laku dan penyelidikan di Institut Penyelidikan Perubatan IMR pada tahun 1987. Bahagian ini mula berkembang dan dinaik taraf dan dikenali sebagai Institut Promosi Kesihatan pada tahun 1999. Daripada lokasi asal di Jalan Pahang, Kuala Lumpur, IPTK telah berpindah ke lokasi baharu pada Disember tahun 2005 yang dikenali sebagai Institut Promosi Kesihatan IPK. Di lokasi ini, IPTK mempunyai bangunan sendiri di Jalan Rumah Sakit Bangsa, Kuala Lumpur. Institut ini mula dikenali sebagai Institut Penyelidikan Tingkah Laku Kesihatan bermula tahun 2007. Visi IPTK menjadi pusat penyelidikan tingkah laku kesihatan terunggul di Malaysia. Misi IPTK menetapkan penanda aras cemerlang bagi penyelidikan tingkah laku kesihatan dan menjalankan penyelidikan yang menyumbang ke arah aspirasi nasional. Penyelidik di IPTK terdiri daripada pegawai pendidikan kesihatan dari pelbagai latar belakang akademik dan kepakaran tertentu. IPTK memfokuskan kepada 12 bidang penyelidikan tingkah laku iaitu pembangunan instrumen diagnosis tingkah laku, pembangunan instrumen penilaian hasil program, tingkah laku kesihatan yang berulang, tingkah laku mencari maklumat kesihatan, tingkah laku berkaitan penyakit berjangkit, tingkah laku berkaitan penyakit tidak berjangkit, penilaian program intervensi promosi kesihatan, penilaian literasi kesihatan, tingkah laku berisiko, kesihatan mental, penilaian tingkah laku pesakit, trend dan penggunaan media. IPTK turut memainkan peranan penting seperti meningkatkan kemampuan dan memperkasa penyelidikan tingkah laku kesihatan, meneroka teori tingkah laku kesihatan, memperkukuhkan kolaborasi ilmiah dengan agensi lain, mengadakan latihan kompetensi dan teknikal kepada kaki tangan kesihatan, menjalankan kursus pasca siswaza pendidikan kesihatan bersama Universiti Kebangsaan Malaysia UKM, konsultansi kepada pihak yang berkaitan dalam pendidikan tingkah laku kesihatan. Arah kehadapan IPTK adalah meningkatkan keupayaan dan kemampuan institut dalam bidang penyelidikan tingkah laku kesihatan.
Okay, hi, welcome back. So without further ado, I would like to welcome Dr. Zabri to begin his presentation.
Thank you, Komathi. So for that very, very lengthy CV review of myself, thank you so much. Just to inform everyone, actually it's happenstance that actually we had a CME last week with Dr. Haliza, and she was our collaborator for this survey itself, because we were, how shall we say, running parallel with the NHMS. So just so happened, secara nasib je, we were doing this together, and we also present it in sequence. So you will see such similar parallels of both journeys, I believe. So here today we will be discussing more on the learning points of what we've gone through when we did the Malaysian Health Literacy Survey. So just an overview of MHLS 2023. This actually is the second iteration after the 2019 survey, to which one committee next to me was the original PI then. The first iteration, the tools were developed roughly about a year before, where it was developed and validated with collaboration with UKM then. And the intention of this survey then, now and in the future, is to intentionally measure the levels of general health literacy in the Malaysian population, where in 2019, at the first iteration, we were looking only at the adults, and in 2023, we introduced the adolescent health literacy component on top of the existing health literacy survey. So before we continue on, this word literacy has been thrown literally everywhere, and in various terms. I mean, in various components, in various different variations. So let's talk about literacy on the concept by itself. So literacy, in its general definition, is the ability to write, understand, and use written language effectively. So, and these concepts of literacy comes in in different forms. Of course, the most basic one, the basic literacy, would be the ability to read and write. Ni memang yang basic sebetul-betulnya when it comes to school level. And also there is the functional health literacy. Functional health literacy focuses on the ability to incorporate numerical skills on top of the basic skills. And then lepas tu yang sekarang ni sangat famous, which is talks very much about, is digital literacy, which the ability to use digital tools and technology for everyday life. And we know Malaysia has a 97% of internet penetration and a very high level of digital literacy. However, exact numbers, I think, is still in the works. We assume that this would be done by the Kementerian Komunikasi Multimedia. We assume that they will be doing the measures of digital literacy. So the fourth one would be health literacy. This is what we were going to talk about. I'll continue a bit on. But the last one would be focused literacy on media, financial information literacy, and even others. So this is where the ability to understand and critically evaluate specific information on different types of literacy. Now, let's look at health literacy, the one that we're going to talk about today. So health literacy, in its definition, is the ability to obtain, process, and understand basic health information and services to make appropriate health decisions. This is applicable when a person wants to seek health services, going through that services itself, and all the way to going through the treatment to ensure effective outcomes from the services that they gain. And this is reflected through the ability for them to process and understand these informations and apply it to their own self. Now, there are 4 key component areas in health literacy, and of course the first being accessing information, where knowing where and how to find reliable information or services that they need to obtain. Secondly, understanding these information, because as patients, you would need to comprehend medical terms, instructions, prescriptions or labels given to you, or even the health advice conveyed to you by your medical professional. Thirdly, the ability to evaluate this information, meaning the ability to judge the credibility, the accuracy, the relevancy of the health content that is given to you, to know what is actually myth from fact. This is very important because this is the biggest issue right now. A lot of people tend to share misinformation, tend to think that this misinformation is correct. So this is the critical part of health literacy that needs to be conveyed. And of course, in the end, using this information when you want to apply this knowledge to make informed decisions about your own health and managing, especially when a person has a chronic condition, or even following treatment plans, or even seeking care when and how at the right time. Now, why is health literacy so important? So because health literacy is extremely important, because when you have good literacy, you will be able to understand, for example, the need to do cancer screening, and understand the information, that the brochure that was given to you, why you need to do your mammogram, for example. You also need to be able to have good literacy to be able to navigate the healthcare system. So you will know that when they tell you, Puan kena buat X-ray scan or other types of scan. And then dia tahu ke mana dia kena pergi. And of course, it's important to have good literacy, so you will be able to communicate effectively with your doctor. So, bukannya bercakap ayam dengan itik. That's the simple term that I can give an analogy for.
Okay.
So, and then, of course, you'll be able to follow the medications instruction accurately to have the best outcome for your treatment. Now, when a person has low literacy, it is often associated with poorer health outcomes, and the person may have increased cases of hospitalization, and they won't be able to use preventive services effectively. And this, in the end, if it's reflected overall to our population, an increase in higher healthcare costs. This is why health literacy matters so much. Now, for the conduct of the MHLS 2023, the original version, the first iteration, it was conducted as a sub-module under the NHMS survey of the same year in 2023, or rather in 2022, during the development phase. It was upgraded as a separate survey, but we ran along with Dr. Haliza's team for the NHMS 2023. The wonderful thing of running together is that both years they were linked to the non-communicable disease team, the NCD team, because NCD is a major burden of disease for Malaysia, and it is tied closely to health literacy. And having the benefit of combining these two data sets, so health literacy can function as a proxy indicator to the general health status of Malaysia. So that's the wonderful thing of running these two surveys together. First of all, I would like to say, on top of the support from the Institute of Public Health, the Director, Principal, the Investigator, I would also would like to thank you, our own Director, who functions as our advisor, and of course our stakeholder, the Health Education Division, so providing support and even some amount of funding to conduct the survey. As I said, we have conducted this together with NHMS 2023, and when we designed the survey, because NHMS 2023 is very, very big on its own, it has a lot of modules, so we designed it in such a way to minimize the burden of NHMS, but without compromising the core of our survey. So the tools developed is designed mainly stream towards the NHMS format. You can see the, oops, oh, I can't focus it. Never mind. You can see on the right side are the two format books, the questionnaire books for the adults and adolescents, and is designed according to the requirements of the NHMS formats. So this is to ensure standardization, minimization replications in variables such as social demographic and basic health status, and even disease status, to which, since we run parallel, we can obtain this from the NHMS survey itself by sharing of data. And of course, sharing of resources in terms of manpower, facility, and technology, will be able to combine all the process together. So we would be able to run the survey as smooth as possible. So for the conduct of the survey itself, we had the data collection training together with the NHMS team. This was conducted twice, once in Bangi for all the Semenanjung Malaysia teams, and also in Sabah for the Sabah and Sarawak teams. For our training, we focus mainly on the survey requirements to ensure maximum outputs, and all the possible scenarios and possible questions that could happen on the ground. So during this time, we did a lot of dry runs and scenario training, that if things should happen on the ground, so how would the data collection team react to? And this training, there is also a training for the data management. This was conducted right here at NIH, specifically at the IKU, for the data processing and quality team. The DPQ team is led by Dr. Lian, which helped us mainly for the processing and data quality. So we thank her for these efforts. And the training is done mainly by us, of course, and to serve the purpose of the survey. Now, on top of after the training was conducted and data collection commences, we have constant meetings and supervisions. So we have meetings at the central level, which we call the Central Coordinating Team with the NHMS team, where we present weekly updates to the entire team to ensure whether there is problems down at the site. Whenever there is problems, so we would convey these solutions to the teams on the site, or even request the state coordinating teams to go down and help if necessary. Even us, the principal investigator, would also go down when needed. So we have to ensure that there are no what issues that is felt down on the field is solved as soon as possible, and the same information is spread throughout all teams so that no similar issues would appear elsewhere. So field supervision, we went several times, but we only have a few pictures here. We conducted randomly, and the two pictures below are shown. There are field supervision that is done in Sabah. This is done by my team. I did not go there. I attended the one in Sarawak. We had two supervisions, one in Miri and one in Kuching. We weren't able to join the team in Cebu because they were moving around, so we only managed to catch them at these two places. Once the data collection was completed and analyzed, we had multiple presentations, and these presentations were done in succession. The first level would be the presentation to the institutional level. Then we had presentations to the stakeholders, the immediate stakeholders, to share the initial outcomes of the data analyzed, whether it fits with the information that they need. And of course, we would have different sessions as well with the different layers of stakeholders. Then once these are cleared, we did our presentation to the Deputy Director General and the Director General of Health to share the outcomes, and this was in the end also shared during the launch of the NHMS outcomes event, where we also shared part of our results on that event itself. An additional presentation that was done for MHLS was a special presentation to the Minister of Health and Parliament. This was on the behest of our main stakeholder, the Health Education Division, because at this point of time, they were implementing the Agenda Nasional Malaysia Sihat, and this involved multiple ministries. And they were also proposing a study for Putrajaya Sihat Sejahtera. So they shared the results of the MHLS and partly NHMS to see the actual status of Malaysians' levels of literacy and health status to justify the conduct of their activities. So coming to to the overall of the survey, one would always ask, is there just one health literacy? The answer is actually no, because the general health literacy that we conducted the past, I think, 2 cycles, is mainly focused on the general health literacy, on healthcare access and knowledge and behavior on how to get to healthcare services. However, there are many, as I said earlier, there are many different variations of literacy, and even in health literacy, there are also variants of it. Recently, at IPTK, we have developed several tools, and one of it is the mental health literacy, which we developed the tool, validated along with the scores in collaboration with international researchers from 7 different countries, with the main collaborator from Portugal. We also, which one Komathi is right next to me, has developed the tools for SALT literacy. Is developed and validated, and both tools would intentionally be implemented for a grand survey, which we plan to do in the future. And we are also in the works of developing a cancer health literacy. This is a new project in development, because cancer is now becoming the thing to deal with. Now, way forward, we thank you, the collaborations with the NHMS team, the Health Education Division, and even the state, because implementation of a big survey is very complicated. And through the NHMS, we learned a lot of differences in implementation, how things are done at the state, and how it is managed at a national level. So getting this live feedback through the weekly CCT meeting gives you a fresh perspective of how surveys are conducted. Because I've done surveys before, but it's on a different capacity, but let's not talk about that. But at this point of time, after developing the 2 additional tools, we at IPTK are looking at the possibility on conduct of a grand literacy survey, encompassing different focus of areas of literacy. But of course, we have yet to fully develop this, because on the complexity and the large scale, we have yet to fully design how the survey would work, and how the management would work. For the past few years, we were lucky to have the collaboration with IKU. So if we were to implement this larger literacy survey, we would have to rethink on how the implementation would work. I would like to say thank you to our collaborators at IKU, our stakeholders at Health Education Division, our director for giving the support all the way until completion of the survey, and of course to the steering committee for giving us the chance to do the survey and to assist in streamlining the way forward for the National Health Blueprint. So if you are interested in looking at the outcomes of the survey, to which I purposely did not share because this is a sharing of experience, you can have access to the reports, and you can simply search under our NIH repository or library. You can just search for it, you'll find it, and you can have access to the report, to the research highlights, and the fact sheet. If you can't get it here, you can just search it off directly off the internet. So thank you very much. If there is any question, I will take it at any point of time.
Okay, thank you very much, Dr. Zabri, for a very insightful presentation just now. Actually, you brought us through it's like a walkthrough of your process in conducting this journey as a team in our institute, and it's a collaborative effort with IKU as well. So basically, I would have one question for you. Actually, this term of health literacy is being prominently used. What would you say, how would you differentiate health literacy assessment with a KAP assessment, the knowledge attitude practice assessment? How would you differentiate the assessment for these two domains?
Right. KAP is generally mainly looking at the knowledge to practice, or CAB, cognitive, affective or behavior. They differ directly from literacy is because literacy goes beyond that. Because KAP assess the immediate assessment of those domains. But when we look at literacy, when you implement literacy into it, you are looking beyond that and the effect of it, because the outcomes of it would in turn that gives you a proxy that a person is capable with that good level of knowledge be able to act on it. So there is where health literacy measures slightly differs from the KAP. So it's a step above sebenarnya. So so that's the main difference between the two. To say it is the same, I would rather beg to differ. But it is a step above the standard KAP survey.
Okay. Another question. Could you share what was the challenges that was faced by the team throughout the conduct of this national survey, especially when it's related to the health literacy assessment, and whether the challenges are actually different in Peninsula and Borneo?
Well, health literacy is designed to measure the three components and the ability to apply them. When we designed it, it was done in two languages, Malay and English. Of course, when we did the CCT meetings, the teams would struggle in certain areas because the sampling of LQs and EBs was done purely random using the NHMS methodology, which comes from DOSM. There are instances where you would find populations with language barriers, both in Peninsula and Sabah and Sarawak. We had EBs and LQs which was predominantly Chinese. By right, language should not be an issue because the population will be able to speak in both English and Malay. But these were purely Chinese populated, and most of them were elderly. So in one of the outcomes of health literacy, education plays a significant part. So when the person does not have that that standard national education, so they would have trouble reading the survey itself because of the language barrier. And this also occurs in Sabah and Sarawak, where indigenous population which has problems in understanding the standard language would have in Sabah and Sarawak as well. So these are the main challenges. And also there would be issues of trust. I think issues of trust occurs in every national survey, because especially recently when a lot of surveys was conducted online during the pandemic, there were a lot of scams occurring. So when we went at the physical level, so the trust was even more difficult to obtain. So we depended heavily on gaining the trust of the population when we want to do the survey. So to mitigate this, most of the time the scouting team of the NHMS would liaise with the local leaders on how to reach to the population. Although it covers much of the population, there will still be pockets of population who refuse. So this is quite common. But we were lucky that we get for MHLS, for the adult population, we were able to reach our target population. However, for the adolescent population, we had quite a miss within the population, where we could not reach the numbers required for the sample size. So that was the little drawback that we had I won't say little, but the drawback that we had then. Yeah.
Okay, so going back to the one that you just shared just now about conducting the adolescent health survey in the population, so I would refer to your past experiences. So as a lead researcher for the YBRFS, Youth Behavioural Research Surveillance Survey back in 2013, where it was a national survey among adolescents, but was conducted in the among school-going adolescents. So now you have actually had experience of conducting a survey in school-based, and now it's a population-based. So what actually you see the difference that you actually encounter, and was there like a change? Because it was 2013 and now it is like 2023. What could you share from your preview of the conduct of this research? Anything interesting to share?
Yeah. Well, YBFS was actually conducted in 2011 actually. 2010 and 2011. And then it was upgraded as part of NHMS in 2012 as the Global School-Based Health Survey. I was the original PI then, and then the present pengarah of IKU took over as PI when I went for my PhDs. So in comparison to household survey, school-based survey is way easier to implement because it is a targeted population. So a closed population. A closed population means that you would have a closed audience where you don't need to search them where they are, and gaining access to a closed population is much more easier, not as complicated as a household survey, and the cost of implementing for a school-based survey is much more, I would say, less costly because they are a closed population, because they are in a school. So in comparison to a household survey, where you have to go from house to house, school-based survey, your concentration will be at the schools. All you need is to get permission from the school one. Of course, Ministry of Education, of course, the state level education, the district level education, of course, finally the school, and on top of that, parental consent. Although it looks complicated, but it is not as complicated when you go to a household survey. So that is the main difference. So the implementation of a household survey versus a school-based survey is actually less costly, less intensive, and easier to implement rather than a school-based survey. That's why I think Dr. Ani can attest that the cost of running the two different surveys is very, very much different. Yeah.
Okay. Was there any difference in terms of the time period then and now, would you say, like in terms of responses of the participants?
Well, it depends on how it is implemented. Back then, it was most of it was still paper-based. Although now we still do implement paper-based methods, but we are moving more towards technology-based. Most surveys actually do use technology, inputting data via tablets and whatnot. This would enable direct feed of the data into the system, the REDCap system, which is used by the NHMS and even our MHLS. We have our own separate REDCap database. For us, we use the dual. We still use the paper method because because of certain limitation, we use the paper method and also the tablet method. So what happened was, for our survey, after entering the data on paper, the data collection team will also feed it into the tablet for the live data, and the paper survey would be shipped back to IKU, to the DPQ team. So the DPQ team would receive, cross-check that data to ensure that the data entered was correct, to ensure all the information was correct, because one of the main criteria for MHLS is exact completion. We use the term exact completion because that is the requirement for the health literacy. If it's not complete, then we would have to remove it from the data set, because to conduct the analysis, it has to be a complete entry for the survey book form. So those are one of the pre-requirements that I mentioned, but there were a lot of more requirements that let's not go there.
Actually, I think because of the previous CME also actually I think spoken a lot about that. Actually, I'm interested in more to this, was there like skepticism among the respondents down there in the field? Because like now, like when they have so many scammers calling us and saying that, I don't know how they get the numbers, even I also receive the calls, you know. So do they like very cautious when they give me the details when it comes to filling up the questionnaires? So I want to see the time period of then and now. Do you have anything interesting to share?
Yes, of course. There are instances where the data collection team gets questions or gets questioned on the identity of them collecting the data. But this is where the mitigation process done mainly by IKU. We thank them for this purpose on doing a lot of the media coverage for this one and linking the survey with the community. So it is fantastic or the work they did to enable both teams, well actually 3 teams including the GATS teams, to conduct the survey together. So as I said, sharing of resources that enables us to conduct all of the surveys at one time. Of course, when entering the data, after they earn the trust of the data collection team, so of course the population was more responsive in giving the information, and we ensure that the personal information that they do enter within the survey is not leaked in any way. We adhere to the Helsinki Declaration to protect the information of the participants, masking them and never revealing them.
Okay. We have one question here.
Yep.
I think it's more like a suggestion.
Yep.
Okay, just give me time. Okay. Okay, with the high penetration of smartphones and IT literacy in Malaysia, do you think online interview or survey is the way forward for population surveys in Malaysia?
Yes and no. Yes, because of the high penetration, 97% of the population of the internet onto the population. In fact, usage of peripherals is for Malaysian population is 125%. You can check it online. 125% meaning that a Malaysian person may have more than one peripheral. Even for me, I have 2 with me right now, and I have more in my office, and I use all of it for all intents and purposes. So yes, it is a way of going forward. But having said that, this high percentage of usage is mainly in the urban areas, and mainly with those with higher digital literacy and with higher economic status. So meaning that if you were to use this as a main method, the probability of your data being skewed is also there. Unless our population, fully utilizes this technology overall, when I say overall, including the rural area, then that would be the best way of doing it. But if you were to do it, then we will only cover a portion of the population. I would say probably up to at most around 70 to 80%, while we are leaving out some population gaps, mainly the elderly, mainly those of the lower socioeconomic status, and those who are digitally illiterate. So the answer is yes and no, because I would say it's a bit conditional.
Okay, thanks. I hope that answers the questions from the participant. And this would be, I think, the final questions for you today. Based on your experience of conducting this National Health Survey, National Health Literacy Assessment, what would you want to change or improvise the next round of the National Health Literacy Assessment? if you're given chance to be the lead again.
Oh well, let's talk about that later. But but looking forward, as I did mention, we are looking at the idea of conducting a grand literacy survey. When we say grand literacy survey, meaning that on top of the general health literacy, we want to look at different aspects of health literacy as well, which includes the two developed tools that we already have, meaning that SALT literacy and also mental health literacy. So if we can, if we are able to do that, then we would cover a lot more areas. There are actually requests, a lot more requests from our program people on different aspects of literacy. But because most of these tools are not validated or not developed, or even if they are developed, not validated for the Malaysian population, there are a lot of steps that needs to be done before we are able to use it for our Malaysian population. So, for example, the mental health literacy that we finished developing literally this year, the score aspect of it, took us about a year plus to complete that process. And I'm sure that you have the same experience for your SALT literacy. So to be able to use it for our population, we have to go through this process first, and then and incorporate it into the bigger survey. In fact, that our adolescent health literacy survey that was conducted along with the adult health literacy survey was originally intended to be part of NHMS of the previous year, which was the adolescent health survey. But because, if I use the term, kita ni tertinggal bas on the validation part, so we decided to incorporate it as part of this survey. But it's by chance that we were unlucky that we weren't able to obtain the numbers of samples needed. So there was, when we analyzed the data, there was a high amount of residual standard error that we could not generalize the data for the adolescent Malaysian health population. But the data is there, but it's just that we cannot generalize it. So to say that it's accurate for the Malaysian population is not very much, but the data is still good enough for the purpose of validation.
So it's like an indicator.
Yeah, it is an indicator, but the accuracy is arguable because of the high RSE.
Okay, then. So I think that would be the end for our CME session today. I have no questions anymore. So I would like to thank you, Dr. Zabri, for all the wonderful sharing of your knowledge and experiences, and even during the question and answer sessions, you shared a lot of infos for all of us to get to know more in depth about this National Health Literacy Survey, the process and the journey that you went through together with the team. And to all our participants who joined our NIH CME sessions today, thank you again for joining us, and hope it was a fruitful session for all of you. Thank you.